All right, so it's being recorded. Um, I will start, Allison, and then as we'll just kind of go around these boxes here. I'm Cicely Fleming, Alderman of the Ninth Ward in the city of Evanston, and I chair what we call the Alternatives to 911 Response Committee. And so we are taking on the endeavor of kind of designing a team of professionals that will go out and respond to emergency calls that don't need an armed police officer. And so, as you know, doing this work, a lot of different municipalities are now thinking about this. So we've now been meeting for, I think, a couple of months with our goal of being the beginning of February. This committee will kind of generate a report to go back to City Council with our kind of our thoughts on what this program should entail. Ideally, we as a city will get something up and running. I will say we'll aim for, late spring, early summer, but I'm not exactly sure of that timeline yet. But one of our committee members who's not here yet, I think, right? It was not you, Patti. I think it was Maureen.
Yeah. I think she said she'll join about 4:15, I thought.
Who is from Peer Services. She's on our committee, and she recommended that we speak to you all to learn about what you do and what we can learn from your work. So I'll just start based on the boxes I see. So Evangeline, if you want to go next.
Sure. My name is Evangeline Semark, and I'm a 16-year resident of the 8th Ward here in Evanston. And I'm showing up in this committee as a survivor of multiple forms of violence, but most specifically my son's murder here in Evanston in 2018.
Alderman Revelle.
I'm Eleanor Revelle, and I'm the alderman in the 7th Ward, and really glad to be working with Alderman Fleming on getting this program set up for Evanston.
And Patti.
Patti Capouch, the Executive Director of Impact Behavioral Health Partners, and we provide housing, employment, and behavioral health for folks with serious and chronic mental illness.
And then we have Angela.
Hi, I'm Angela Valavanis. I'm on this committee in the capacity of being a business owner. I have a business in downtown Evanston called Creative Coworking, and I work closely with the Chamber of Commerce and the Downtown Evanston organization, as well as being a resident of Evanston.
Kristen.
Hi, I'm Kristen Kennard. I am a licensed clinical social worker, and I am the Deputy Director and Director of Social Work Services at the Moran Center in Evanston. It's a not-for-profit agency that provides integrated legal and social work services, Evanston residents.
Then we have Nicole and Indira, their staff, so they don't, they're here for kind of to support us. Paulina works in the city manager's office, so she's here to listen. And then Sivas is also a staff. He is the manager of the 911 call center, so he's been listening in just to kind of hear what direction we're going. Then we have A. Barnes. Not sure, she might be multitasking. She's our deputy commander of our police department. And so she has been bringing in that input, how the police currently handle calls and how we can integrate this program to work with the police, although they are not police officers. All right, so we have a couple more members who might be joining us late, but if you want to go ahead and get started, we're going to be very mindful of your time, Allison. If you can just kind of tell us who you are and what you do and how your team works and how they respond. We heard from Trilogy before the holiday, so we had a little bit of idea of what their crisis team does.
Yes, I think we do a lot of this, a lot of similar, services as Trilogy does. I'm a community support specialist and a team leader out of Skokie. So the members that we help are primarily in the Skokie, Evanston, and the Rogers Park area. We try to see people 2 to 3 times a week. We work with a lot of folks that have severe mental illness. A lot of our diagnoses are schizophrenia, bipolar disorder with psychotic features, and schizoaffective disorder. So we try to meet with people regularly so we don't have as many crises or need for hospitalizations, just to kind of help monitor more symptoms before they kind of get into crises. We also do have a 24-hour crisis line that our members can utilize at any point in the day. And I know that I have worked with the Evanston and Skokie and Chicago police pretty regularly when we have had to hospitalize people as well.
All right, so can you tell us more about the crisis lines? You said it's open to your members. Is it only open to people who are currently Thresholds clients, or can anyone call from the community?
It is only for our thresholds members, unfortunately. And I think the reasoning for that is because there are other crisis lines available, but for our members, it kind of helps them know that there's a familiar person on the line. We kind of know their backgrounds a little bit more. So it assists with kind of allowing them to use our crisis lines instead of using others that other community members might need as well. And usually when they are calling the crisis line, because we do know their history and kind of more of what's going on day to day, we're able to kind of talk down the crises and not necessarily have to call 911 or do as many wellness checks or utilize the emergency room services.
And then what ages are your patients? Do you work with just adults? Do you work with adolescents?
So the program, so Thresholds is very, very large. So we're kind of all over the place from Kankakee to Chicago to the northern suburbs. So my program, we work with adults aging anywhere from 22 to, I think one of our older members is in their 70s.
Okay, and then when you talk about the, I think you call it CST, is that the name of your team?
Yep.
And it's crisis?
It's community support team.
Okay, do you ever go into the community and meet with people? You mentioned meeting with them 2 to 3 times a week. Is that in your building? Do you go to the community?
We actually, we do have a building, but primarily we do meet in their homes or in the community. A lot of times our folks, because of symptoms of paranoia, they are reluctant to go into offices. So that's why we go and meet with them.
And so how do people become a patient of Threshold, excuse me?
Yeah, so they would just go through an intake with our intake phone number. They would go through a brief kind of interview process. We do a background check and kind of just see if our services, if they would give them a brief synopsis of like kind of what we do with our services to see if they would be interested in that. And then depending on their location, they would be then connected with a team.
Right. Team, so anyone can chime in. I'm just thinking as I go of questions. So, you know, so when you say background check, what does that entail?
So we still work with people that have a background check. It just helps us kind of be able to figure out what it is, what their needs are. We're going to have to help with getting them to like parole meetings. It just helps us kind of know where the members are at. It doesn't, you know, just because they have a background does not disqualify them from services.
Okay, so that is like a criminal background check then.
Yeah, it's a criminal background check, and what like they would also go through like a high risk like committee if they do have like serious like background, like if there was murder or something like that. Again, that still doesn't mean that we wouldn't work with them. It would just mean that we would have a little bit more precautions while working with them, meaning we might go out in pairs, or you know, we might not meet them necessarily in their apartment, but maybe just out in the community or in public. Because we are community support, we're not in an office. We just have to ensure our safety and to make sure we're prepared for anything that kind of comes up.
So what percent of the people that you work with do have a criminal background, roughly? I mean,
Ooh, a lot of people have some criminal backgrounds. Yeah. I mean, and that can range from anywhere from robbery to we do work with people. We have one person that we're working with that does have a murder background, but a lot of them are more like petty thefts, grand theft auto, and we do work with folks too that because of symptoms of paranoia that they might have had some run-ins with the police, and that does not, you know, most people would kind of be a little bit shyer to work with them, but we kind of see that a lot of times it's symptoms that are getting in the way of that.
and so how do most of the people find you? Do they have somebody who kind of connects them with Thresholds, or?
A lot of times we do get referrals from different doctors' offices, psychiatrists. We also do have a mobile unit that does like, I don't know how frequently they're doing it now with COVID going on, but we'll ride the trains and buses and try to, you know, connect with people and get them connected with Thresholds and programming and help with medications and housing and stuff like that as well. So it's a wide variety. I'd say in the northern suburbs, a lot of times our referrals are coming from doctors and also from word of mouth from our members as well. Thresholds, excuse me, I'm so sorry. We also are working a lot with the Williams-Colbert decree. So that is part of, we're helping people kind of move out of the IMDs and nursing home facilities and into the community. So that's a pretty big portion of where our referrals come from as well.
And could you say a little bit more about this mobile unit?
Unfortunately, I don't have a whole lot of information on that. Like I said, Thresholds is really, it's a very, very large company, and I'm just more familiar more so with our Northern Suburbs programs. But we do have a mobile unit, and I can try to get some more information on that. But a lot of times it's more so helping those like in the city, more so than Evanston and Skokie.
Yeah. And so when you're trying to help someone who's trying to move out of a more institutionalized setting into a community setting, what kinds of community settings do you help them get into, or how, do you work with another, or do you help provide that housing, or how do you help them?
So the Williams and Colbert decree came about from a lawsuit. So we actually work closely with HAC and Catholic Charities. They are the ones that actually offer the subsidy. So we still do the assessments to make sure, that they are going to be ready to kind of move out into the community. We work closely with the nursing home staff to just make sure, like, are they taking medications? Do they have the skills to kind of live on their own? Or what can we do to kind of build upon those skills? Like, I work with somebody that was institutionalized for 20 years of his adult life, and he's done amazing, but he never cooked for himself. He's never had to use a stove or anything like that. But that was stuff that we were able to work on and slowly build on those skills to get him out into the community. And they move into apartments that accept subsidies. So that can be anywhere, or it could be in a like HAC building, like that's at, we have some people that live at that 1900 Sherman or the 2300 Noyes building, but we also have people that are just in regular apartments that landlords will accept those subsidized units.
Right. Okay.
And that's been a little bit on hold right now because of COVID and our availability to have access into those nursing homes. A lot of times we're really not allowed in at this point.
Right.
And also just because we're not able to go in or really assess as many skills as we would like, we've kind of put some of that on hold more recently. But we're hoping with the vaccines and stuff coming out that we'll be able to get more and more people out. Honestly, it's a lot of our favorite parts of our job is working with the Williams-Colbert decree, because most of these institutions that they're in are pretty awful, and a lot of them really don't need to be there, and just need some extra support. So that's a huge part of what we do at our program is kind of get people out of those places. Right.
And so what year was that decree?
So I started working at Thresholds about 4 years ago. I think, I'm not sure when it was. I'd have to look that up, but we've been working, Thresholds has been working on it, I know, for at least the 4 years, but I think even longer than that.
Right, yeah, because my memory goes way back a bunch of years where there was I don't know if it was the same decree or an earlier one that was, helping move people out of the institutions. So, yeah, I guess I was a little surprised to think we were still having to do that.
I'm glad we still are, because there's still a very big need for it.
Right, yeah.
So Allison, I have a question. How many CST teams do you have, and like how many clients do you have assigned to each team?
In the north suburbs, so we have 2 different offices. We have one office that's on Skokie Boulevard, and then we have another one that's on Frontage Road in Northfield. And between those 2 offices, there are 2 CST teams. And we are actually opening up our caseload right now for intake. So if people were to call, like, we are accepting people into the program. Right now, we're a little bit lower census because we've lost some engagement because of COVID. People haven't wanted to work with us, or our engagement's just been a little bit lower. So right now on my team, I think I have about 50, and I think the other team is close to that, but we are capable of taking much more on.
Did you say 50, 50?
Yeah.
Okay.
Correct.
All right. And then I'm just trying to familiarize myself, the difference between ACT and CST. So ACT teams, Threshold has those as well, right?
We do. We just don't have them in the northern suburbs at this point. It's something that myself and the other CST team leader are kind of advocating for,
Okay.
just because there is a higher need. A lot of times with the ACT level of care, there's a lot more medical stuff kind of going on, or a lot more medication management, or need for more visits than 3 times a week. And also at an ACT level, they also get services like offered on the weekends. We're on the CST level, we're more so Monday through Friday. And then also we have the crisis line that they have access to 24 hours. But we also have a CSI team in the northern suburbs as well. So that's the community support individual. And those members, they can be seen like every other week or on a monthly basis. But a lot of times they're more so needing just more like support or like check-ins, not as much case management or symptom management, but more so just kind of not as frequent check-ins.
Okay, thank you. I'm just wondering, so if, when you say you get the referrals from the doctors mostly, so would that be clients who are set up with a psychiatrist or a social worker or something, and those referrals would come maybe during the day or something? That isn't like an emergency referral where maybe like ACT is more, there's an emergency and an ACT team gets called out?
So we don't necessarily have an ACT team, though I do work with people that are probably at an ACT level.
Okay.
But just because they need ACT services doesn't mean we wouldn't see them. Us as a community support team would try to meet those needs as best we could. Because we don't have those services, we don't have an ACT team. So we try our best. We will see people 5 days out of the week if we need to. But that's why we're trying to advocate to get an ACT team, because we're starting to see an increased need in the northern suburbs for that.
Yeah.
But at this point, myself and the other CST team, we will just work with those folks that do need that extra level of care. A lot of times where we're getting the referrals is actually through like the Heartland Center in Skokie. I've gotten a few from Connections from the Homeless as well, that's out in Evanston. Also through Access is another one. And then I just started recently talking with like the Annixter Center that's out in Rogers Park to kind of encourage people to utilize our services as well. So a lot of times I think it's more so word of mouth, or just other social workers or counselors kind of pushing towards it a little bit.
Mhm.
And also I think too, in any nonprofit, a lot of us counselors and social workers, we kind of move on to the next step, but we always keep our roots at Thresholds, and we know the kind of help that we can offer. So a lot of times it's other past employees that are kind of recommending others to work with us as well. I've also, because I've worked with pretty closely with crisis workers at the ER at North Shore and Evanston and Skokie, I've encouraged them to, if they have frequent flyers that are kind of coming through, to utilize our intake as well. So I think a lot of times it's us ourselves knowing that the help is needed, to try to advocate and push people to kind of use our intake number as much as they can.
Okay. All right. Thank you so much. I appreciate the information, Allison.
No problem.
I'm curious about the types of support, the languages that you support. So do you have people on your staff that can support people with different languages other than English?
We do have a couple of Spanish speakers on our team right now. We also do have a deaf program at Thresholds as well. So we do have like sign language interpreters, and we would be able to utilize like interpreter services as well. We just actually hired a new staff that she actually just started on Monday for my team that does speak Arabic. But we do work with people, like if English is their second language, we do our best to try to get as many translators as possible. I think the biggest issue too is at medical appointments, right? Like a lot of times people with mental illness kind of get pushed away.
So even if we don't speak the language, we're really encouraging, like, we need somebody here to explain this for us. So we do push for that a lot too.
Thank you.
And I assume you do, but do you all take people who don't have insurance, or are you trying to enroll them onto insurance to make them a permanent client of yours?
We do take people that don't have insurance, but we do try our best to get them on Medicaid as quickly as possible, because that's how we get paid and keep our doors open. So sometimes we do kind of encourage people to kind of start that process as soon as possible before starting to work with us, and then we'll try to follow up. But we do take people, but we do encourage them to at least kind of start the process of Medicaid, which I'm sure everybody knows is quite the process, and without support is very, very difficult. So a lot of times we are helping people kind of get that started as well.
Any other questions from the committee? Oh, go ahead, Angela.
Yeah, I have one. You mentioned something about, someone who might be experiencing paranoia, could have trouble with the police for that reason. Just based on your experience, could you talk a little bit about the kinds of things that might occur with someone who's struggling if a police officer in uniform were to show up to help them versus someone who is not in uniform?
I think a lot of times when the uniform shows up, they automatically think they're in trouble. And that's not always necessarily the case. Sometimes we're calling the police or the paramedics to come and help us try to hospitalize somebody because they're in danger, or they might, inability to care for self or anything like that. So I think as soon as they see the uniform, they are fearful that they're going to be arrested and brought to Cook County, or that they are in major trouble. And a lot of times that's not why we're calling the police or why they're showing up. It's more so more of like a disturbance, or, neighbors might have called because they saw them shouting outside, or something like that. So I think it's just more so that it's that fear of I need to get out of here because I'm not doing anything wrong. What are they going to bring me in for?
And how close, I know you said you're seeing that more north suburbs, they might need the ACT. Do you think that threshold is close to, are you guys working towards having an ACT, or is that just observations you guys are making as clinicians and trying to see what happens?
I mean, I'm pretty low on the totem pole, so observations that we are definitely making, and, just kind of raising awareness to the higher ups that there is a higher need for it. But with COVID, I mean, we are, trying our best to just keep the doors open as well. I know that there's been other organizations that have had to close their doors, and luckily we have been able to take those patients on from those companies. But it's more so we're just starting to kind of let our supervisors know that there is an increased need for it. But I mean, luckily, like I said, we are able to meet those needs at this point, and we just do our best. And luckily, we have very compassionate staff that are willing to go above and beyond their duties to make all of that happen.
All right, any more questions from the group? All right, I think that's it. Thank you so much, Allison, for answering our questions and spending your time with us.
Yeah, no, thank you guys.
And if you could find out a little bit more about the mobile unit,
Definitely.
that would be great.
Yeah, and then should I just email that information to you, Ms. Fleming? Is that okay?
Yeah, that would be great. That would be great,
Okay,
yeah.
perfect. Yeah.
And even if there's a contact for me to reach out to, that would be helpful too.
No problem.
Okay, thank you.
Great, thank you.
Feel free to stay on or have the rest of your day back, whatever.
Okay, thank you.
Whatever you like to do. All right, now my dog is barking. Okay, so that, so I think now if we want to start thinking through from kind of all that we've gathered, I know that Eleanor, you put something just new into the chat, but,
Yeah.
and we did this a little bit last time, but I'm going to take better notes. Stop, please. So much stuff going on. The work from home is overrated. Just kind of what we think, what we think is a definite yes, in our opinion, for this program, right? So whether that's, we talk through the hours that maybe we want to have someone available. We've gone through in-house versus out-of-house, staff, the different skill sets, the language piece. So let's kind of start making our wish list here again. I did think it was interesting that Allison brought up, I'm going to make myself a note to try to reach out to someone, the crisis workers at the hospital. I think that's probably a group of folks who have a perspective that might be worth us hearing from if I can track some down.
Right.
To hear, what are they doing? Like, Allison said, when they're in touch with them, but if they're sending folks over in a referral state, we realize that those people probably are not being checked in, to inpatient services. And so then we have people who are at the hospital needing services, but, are maybe just being referred to, call a number that someone's going to call them back in the next day or so. So maybe hearing from those workers about what they're doing with people who, really need immediate attention, but are not getting maybe not hospital medical treatment. So I have my pen and paper. I'm willing to kind of throw some things down. I know I will say that I, through this process thing, have changed my mind a little bit on the in-house versus the out-of-house. I was pretty adamant about this being a program we staff in the city so that we can really have, good hands on it. But thinking through the skill sets that people need, obviously when we have to look for people who have a really specific skill set, and then all the other pieces, the psychiatry, the referrals, just all the other things that we don't have here in the city. Not to mention, their union issues we probably have to work through with HR, which will take a little more time. The cost of having a staff versus maybe contracting out is likely a bit higher. And so I think I've really, I don't want to say changed my mind, but really thought through if there is a program that is working, does it make sense for us to contract with them and have their expertise already versus us trying to onboard people and kind of find the right expertise? Because there's obviously no guarantee we'd find it and just looking ourselves for staffing. So that's one thing where I am, definitely more interested in maybe looking externally for a lot of different reasons than I initially was when we started.
And that's kind of where I did start, is assuming that we would try to find an agency that already had a lot of these skills and services that we are really looking for. Seemed, and then we don't have to deal with the union kinds of issues is another important factor as well. But so I'm on the same page with you at the moment, Cicely.
So I hear all of that and I understand the complications. I'm still a big advocate for this being a public health service that the city would oversee in some capacity. I think it's really hard to guarantee the different types of quality of a service when you have different, vendor relationships or external relationships. So I'm still in the public health internal city mode in my thinking. I could see it as a staged approach, perhaps, right? Where you start with a coordinator of the services or someone attached with 911, and then you grow, right? Maybe there's an opportunity to kind of use some existing organizations in the meantime, but ultimately my long-term goal would be for this to be under our public health department.
Right. And even if we did go, at least initially, with an existing outside agency, we do have to figure out the coordination and reporting and accountability and all those kinds of things anyway. So yeah.
Yeah, and I think it's also really important, some of the things we heard and that I understand as a resident is, having that face-to-face with people who know the community and who are in the community is super important when you are in crisis, right? And having that ability to know, even if you've never met the person, they've been around the community doing the work. I think that's also really important.
Yeah, although we could gain that through an outside agency that did have already existing strong connections with the community. So, yeah.
Yeah, I agree with Evangeline, and I've just been talking to a lot of being a clinical mental health professional, talking to a lot of others. I watched the Treatment Not Trauma, and I've just been doing a lot of other research anyways, because I do respond in a crisis manner to our clients at Moran. And so I'm doing this all the time. And I think between one, trying to find something that exists and has the capacity, and that the city, the public health piece of it, I think is really important, because relying on whether it be a not-for-profit or, whatever that might mean, I think could prove to be really difficult. And then the other things, I know, Cicely, you just kind of said things throwing out there, so I'm kind of all over the place. But I think we talked about this and landed on that, but in regards to like the co-responder model, I'm pretty set on it not being, an officer going out with somebody. And I also really like the idea, which we've talked about, of whatever that team might look like, a mental health professional. I think it is a good idea to really talk about and think about getting some type of peer support person as on that team as well. So whether, you have some type of clinician, mental health professional, I don't know, we've talked a little bit about whether an EMT would be part of that, but having that peer support person on a team as well, I think would really help to engage. And that's what we're talking about. Even Evangeline, we were talking about somebody familiar with the community and somebody who may have experienced some of these things themselves. And it just brings a different level of the ability to de-escalate and also just relate to. So I think those are some of the things that really stick out for me.
Kristen, I think that's a really great response of like the peer support with that too. That's something that we work on in Thresholds too. We actually have a lot of peer support staff. And that does help a lot of times, like before a crisis happens, for somebody to really just feel understood in that moment. I think that's great that you guys are thinking about that.
So how do you bring the peer support staff into the picture with one?
Yeah, they're just regular employees, but some of them they will share their experiences with us. So I have a staff member that works with me who suffers from severe depression to the points where she has been hospitalized and had some suicidal tendencies in the past. We also have people that do have diagnosis of schizophrenia as well. But they're taking their medications, they're complying with their treatment, seeing their therapist regularly. So a lot of times it just helps people know that like your life can be good. It does not have to constantly, be taken over by your symptoms or just have a bad stigma to it all the time. So I think it really just helps instill a lot of hope for people.
All right, so we have the peer support, which I definitely, think would be excellent. We definitely, I think we'd all agree we have to have a language piece, or not language piece, but bilingual and not just Spanish, but whatever languages we can capture. And there's Evangeline, we can look at what the language markers are in Evanston. Obviously, I know Spanish is very high, but there are other languages that.
Arabic would be the next largest growing language in Evanston.
Okay.
2 years ago, that might have changed.
And then, so if we think about, and so I would just tell you, part of my thought with the external piece was watching our health department through this COVID and how thinly stretched they are, unfortunately, based on, I would say probably decades or 10 years ago when they started really making it less of a medically focused health department. And so I think that's my concerns with adding in another program there and making sure it was like a targeted program for this purpose in the event that obviously, right, COVID's going to keep going, and just that this program is not, stripped down or impacted by the health department that's already unfortunately very understaffed. So that was part of my issue, or part of my thought. But then also was hearing from Trilogy last time, and that they're already working in Evanston. I realized they're not only Evanston, but that they do have some Evanston connections, that the hospitals are already calling them, and that they already had kind of that long-term support piece put in. So that if, this person who's responding to the hospital or wherever the call is already has a pocket of support with the psychiatrist and medical and everything to plug someone into. And again, not that it's, not possible, but I very much started in the point of city staff, city program, city more control, because I want to make sure people's calls are being responded to. But then I started thinking about, okay, if our staff responds, we don't have that other piece in-house. So who are we then referring to for those other pieces? Because I really am concerned about the referral process. And I know it can go either way, but if our staff is kind of doing an intake, where are we referring to? And are we making sure those referrals took place and that people got the long-term care they needed? And so that was part of my thing, listening to Trilogy. It sounded like they had all of that already in place. Now, I haven't experienced it, so I don't know if it's, really all working. But, Kristen, you talked about referrals, and even in Evanston, we have a lot of nonprofits. Even the referrals between our nonprofits in the city don't work. And we definitely, Evangeline, to your point, have had contracts that have not worked, right, with local nonprofits. And then we have some that work really well. And part of that is for us as a city to make sure that we're managing them and they're written correctly and all those kind of things. So that's what kind of led me to externally. But okay, so peer language, we're kind of a little bit split, I would say, on the internal versus external, but we can figure that part out, I think. What are the skill sets, right? So we've talked, does everyone agree with Kristen that we have decided as a committee that the co-responder model is not one we're looking to suggest?
Correct.
Yeah.
Okay.
Yeah, no, I mean, I think we're really wanting to get away from having a uniformed officer be part of this. So, yeah.
Okay. And then the EMT piece, I can update you. As you might have known, Chief Scott is retiring. He told me that what he presented to us on the ECHO model, they're kind of at a standstill wanting to see what this committee recommends. They are planning to move that more to a community, sorry, like having an older toddler. They are wanting to have us, well, not have us, but they are wanting to see what we decide. Their goal would be to have their model be more community responsive. So not just responding to people who have been seen at St. Francis, but responding to a slew of people in the community. But it still would be, kind of the ambulance EMT model. He did say they had talked through like an SUV or something of that sort. But, do we think, for me, I didn't think that's where we were trying to go. I think a community medical response is awesome. I don't know if someone who is having some kind of severe mental health, emergency is going to respond any differently to an ambulance and an EMT versus, a police officer. So I didn't think that was quite what we were looking for. But they're kind of in a holding pattern, waiting to see what we do. Just to give you an update on that EMT piece. I know, Eleanor Revelle, you spoke about having a medical professional.
Well, just
respond.
because the models in a couple of other communities, the pair is a behavioral mental health professional and some public health person, just because there are some sort of minor medical, Band-Aids and things like that that the person in crisis may need, but not an emergency kind of medical situation. So so it wasn't the paramedic version necessarily. It was more, but I think when we talked about it before, we said we needed to find out how often the people that we be needing to be responding to, how often do they actually really have a medical issue, and is it more, I think we need a better sense of the kinds of crisis and the individuals that we're trying to help with the program to get a better sense of that, I think.
And that was a question I was going to ask James, as he's not here today, but as he does outreach with our homeless. DC Barnes, are you on? I know she said she was balancing 2 different calls, so I'm not sure if I can try to text her, but Christian, what would you say? I know you don't do a necessarily emergency response, but when you're responding to folks through your job, are you finding that they need medical help, or do they just need your help?
I think it depends on what part of the crisis I get called in on it and by who, right? My client or a parent or somebody like that. I would say there has been medical components to it, and that's generally small stuff, Band-Aid stuff that ultimately I can help them do, right? It's I punched a wall and now I need to clean up my hand, or different things like that, which I think you wouldn't need an EMT or something like that to do anyways. I think generally it's more the the de-escalation and the, bringing them down, then removing them, from whatever environment they're in. So there has been times where we've had to, where they've needed some medical care, and generally that's me bringing them to the emergency room then. But overall, I'd say it's mostly the, behavioral health crisis piece of it, with potentially small medical issues.
Well, and if we were looking to have a team that's got a mental health professional and then a sort of a peer support person, we don't really have room for a medical person as well. So that, and maybe we asked that the team have basic first aid training, but they wouldn't have to be a super medic.
Yeah, and that seems like, I would imagine from listening to what Pierre said, when they go out, and maybe even Allison's team, they probably have some of that. I mean, if they get there and assess that medical is needed, if this ECHO program kind of revamps into something else, maybe that's just another referral we have, right? They call the ECHO team, who's not coming with the sirens and all that, to respond, and not, and not needing to have a medical person with them.
And I will say too, like sometimes when we do go into like a crisis situation, we are still calling 911 because there are times where we still have to do an involuntary hospitalization. We do our best to de-escalate the situation, definitely. But if we still feel that the person is unable to care for self or is in immediate harm of themselves or others, we are still going to need the police in an ambulance to come, because we cannot physically force anybody to go anywhere. So a lot of times that would require a written petition, and that can be done by anybody. But unfortunately, we don't have the means to restrain anyone to get them to go anywhere. So like that is still a piece that is important to have, that we would still need the police and paramedics to kind of understand what we're doing and understand that we've done our best to de-escalate the situation as best we can. And now we're kind of calling in the last resort, because we don't necessarily want to hospitalize people. That's not our goal at all, but there are times where we do need that.
Yeah.
And Barnes, did you just come on for a minute? All right, sorry, the police are very busy, I suppose. Okay, so basic, medical CPR, some kind of skill set there in case there is, some immediate small medical need. Maureen, thanks for joining. So we're just kind of going over our wish list, must have for this program. We haven't really gotten into, and I could leave that for the professionals. We haven't gotten really into if there's a certain certification or degree or credentialing that we think people need to have. We did, Kristen brought up the peer support, and we all thought that was if we can get that also would be a huge benefit for us. But are there other, sorry, Barnes is texting me, she's trying, they've had another issue. But if you have anything you want to throw in, go ahead and do so.
Yeah, thank you. I apologize for joining late, everybody. I was delayed. I love the peer support idea. I think a lot of substance use outreach programs that were developed during the rising part of the opioid epidemic used people in recovery, peers in recovery, who demonstrated their ability to reach people. It's such a different way and such a different level, like to convince somebody to come in off the street, or to convince somebody to come in and actually be willing to talk to somebody about their mental health issue. It really is a very subtle process. So I think that is brilliant. And there are increasingly certifications and training, processes on both the mental health and substance use side for all of it, for peers. And so we're able to better support them too. Because it's not easy, right? It's a hard thing to do. So I definitely support that. And I think that from listening to the different kinds of, as we went through the process with the dispatch folks and listening to DC Barnes and her colleagues and other City of Evanston folks dealing with crisis, it does seem like the wide spectrum of mental health crises is the biggest need. I just would encourage that if people come in without really any substance use crisis experience, that we get them some good training around in managing intoxication and how intoxication interacts with everything. Because, you know, to do I think creating an alternative response program that inadvertently winds up with lots more arrests of people related to intoxication, that's not what we want, right? So being able to manage and de-escalate an intoxicated person is a skill set. We sometimes have to do it here, so you know what I'm talking about. So we're happy, and we'd be happy to help with that. So those are I think my main things.
And are there professional or educational things we want to identify? I know people have thrown out just generally like a social worker, but I realize there's a whole gamut of folks who work in mental and behavioral health. So as the clinicians on the phone or people who have more experience than I, are there certain licensing or, you know, years of experience or certifications that we think we really should be looking for?
I mean, I think that if we're able to combine it with some type of, you know, peer partner type thing, I think it is important to have somebody that is licensed. Liability issue, I mean, there's just so much that comes with it, and the ability to supervise, oversee the peer in regards, if this peer is somebody from the community, even if the mental health professional is somebody from the community, there's so many boundary issues that you're going to be out, you know. I think it's important to have at least a master's level mental health or behavioral health person. And I think it's important for that, ideally to be, you know, licensed clinically. But that's where I stand with it.
Kristen, I would agree with that, just because if we're looking at the time frame around that, I know that when Indira talked about her being sort of on call 24 hours, I would see that this is something that would be needed more in the, you know, in the overnight hours when a lot of agencies are closed. And so having somebody that has that clinical master's level, because they might not necessarily have a supervisor to go ask or whatever, they're going to be out in the night and all of that stuff. So I do think that's important that they have at least a master's level for sure and licensed. I would agree with that.
I agree too. And I think if we wind up contracting with an organization, you know, they can get their supervision internal to the organization, which provides some benefit, I think, to the city in that regard. But their comfort and will in making independent assessments and evaluations really important too. So the person that, for example, that we just hired to do outreach at St. Francis has 4 or 5 years experience and has either finished or just about finished with his licensure hours, and also he's just an amazing person, right? So also there are personal qualities to this, somebody's ability and willingness to meet the community, people in the community in a particular way. But yeah, I don't think it needs to be a 20-year person, but they need to have seen a fair amount of stuff already to, you know, to be that independent.
Yeah, and I think the experience with that, obviously to get licensure, you have to have a certain amount of hours and direct, you know, clinical experience. So I think that we'd be getting two things at once, right, in regards to, and we'd have to look for a certain type of experience, but with that experience on top of that licensure, I think we'd be hitting both of those boxes by doing that.
So let's ask this: if we, you know, are weighing a scale, where do we? I know we talked about familiarity with the community, and then there's the experience and your, you know, ability to get the job done, right? So we love, I guess, imagine this, but which one is most important, right? Like Evanston prides itself as being this really unique place, and if you're, you know, can understand it and work here, you're doing really great. But if someone has all these other criteria that we think are really important or experiences, can they get to know the area, or is that where we look for this peer support that actually knows the area well, right? So maybe that's the the real strength that they bring in, even though they don't have a license, they have the lived experience and personal connections. And then we balance it with this person with all these other great educational, practical experiences. Would that be like a place we would feel good about? I'm just trying to think through the licensing and the experience we're looking for. That person might not know Evanston.
I think we would start out looking for someone who could do both.
Right.
And because since a lot of what might happen is that, trying to refer the person to the appropriate support organization, the person's going to have to get up to speed really fast on
Right.
the resources in the community. So I just think I would say we are looking for someone, people who can really do both, have the licensing and the experience, the clinical experience, plus the understanding and knowledge of the community. I think that's where we need to just start.
Okay.
I would agree. And I think from what we've said here, that there's so many different resources and so many nonprofits in the space. It's hard. I mean, I don't even know all of them yet. And so, and I would say that probably goes for a lot of other folks too, but it's somebody that needs to know the critical ones,
Right.
the ones that most certainly help in the crisis situation, how to refer, how, those type of connections, I think. So I would think the peer would be more like what you were referencing, Alderwoman Fleming, about the peer knowing the community, I think is really important. And I think the professional could learn it if they didn't know the community that well. But I feel like the education and licensure is really important, kind of outweighs that part.
And then Patty started speaking about the times we want this person, because we know we can't have, just a couple people working 24/7. So based on what Chris Voss gave us and what I think Patty brought up, if we only could start with limited coverage, what we'd be looking for nights and weekends, assuming that some people are more stable during the day or have some more supports during the day?
Yeah, I think based on, and again, there's so much more information that we don't have, but based on the information that he did give us, I was looking through it again, and I think where you see most of it coming in is right, like later in the afternoon, early evening until right, like that midnight, 1 o'clock. And then we heard from DC Barnes too, in regards to, weekends and evening, right? Like when police end up getting called in because there's nobody else there to do it. And so I think that the nights and weekends thing, at least to start, even based on the calls and based on what DC Barnes says, that makes the most sense.
Mm-hmm.
I'd like to ask Angela from a business perspective. Does evenings and nights and weekends, does that resolve business owners' concerns, or do we need a different time? Do we need coverage at a different time for that?
I think it's safe to say that, like early morning hours is when a lot of the problems occur with, maybe a break-in or someone who is perceived to be threatening in some way. So either as someone's leaving a business later at night or coming in first thing. So I think, yeah, the nights and weekends coverage would be serving the business community in that way. Yeah, and I keep thinking that in terms of the, outsourcing versus city staff, the people that we talked to from the city staff were so amazing and passionate and clearly trained and in the trauma-informed methodologies and all of that. So I think tapping into that resource is really an important piece of how we make this happen, and whether they are in charge of, developing the kind of resources for someone who is from out of town. Well, they'll get trained by our in-house team on what they need to know about which services are here and at their fingertips. And then also maybe the city staff is handling the piece of making sure that there is follow through, and that there, these frequent flyers and people that we're gonna continue to see, that maybe there's some system that the city helps with tracking to make sure that people aren't falling through the cracks.
So Angela, when you talk about city staff who provide this kind of response. So what are these police officers? Are they health department or what? Who are they?
I was thinking more the people that we talked to who were like the youth services department,
okay.
they were phenomenal. And it seemed like they were the people who were showing up anyway when there was someone who, you know, needed to be talked to in some way. And so if we look at who we already have, who has this kind of training, and
Right.
we build on who we have.
Right, yeah. Yeah, and that is a piece that we do need to talk about in sort of fleshing out this program is how this integrates with the existing resources, particularly the youth and young adult program. Yeah.
All right, I'm going to try Barnes one more time to see if she's back.
I'm
Oh,
here. Good afternoon.
good afternoon. I realize you're juggling 3 different things. We have a quick question for you around the medical piece and then the hours. So Autumn Revelle had brought up the point earlier about her thought initially was one of these staff would be one with more medical training. So if you can, and I know this is kind of a needle in a haystack, but if you could kind of help us understand when you guys are responding to these type of calls now, where it's, you know, mental illness or something else that doesn't really require a police officer, or maybe just a homeless person or what have you, are you frequently needing medical support?
I think it varies. So once the officer arrives on scene, then if they do need ambulance support, then they call for it at that time. But it really does vary.
And if they don't need ambulance support, but a person has, you know, some other small minor woundish kind of a thing, your officers, you know, they all have first aid and such. So they're able to do some, I don't say patch up work, but something very small there on the street. Or do they usually tend to not do any of that and just call an ambulance?
They're calling an ambulance.
Okay.
They're not performing any type of first aid on the street.
Okay. And then we were thinking through the hours. If we, you know, have staff that we can't have coverage 24/7, would you say kind of that afternoon, evening, weekend time is where we should start to try to put coverage initially?
Well, it just seems that those are the times, and I think someone mentioned it earlier again, that the police are called when there's no one else to call. So probably just giving coverage to those times when it's not usual business hours would be a good idea if we're
Okay.
moving forward with a model where the police aren't to be involved.
Okay. Does anyone else have questions for Barnes from the police perspective before she has to go back to another call? Okay. Thank you, Barnes.
You're welcome.
Okay, so I am going to actually this time type all this up. So we have a working document to go from. I'll send it as an email attachment. I can also put it in our Google Docs, which I will remind you what that link is in an email. So we can kind of refresh ourselves on where we've been, what we have. I will try to see if I can find the crisis staff, whoever they are at our hospitals, to get some input from them. I didn't even know we had them. So to get some input from them. And if there are any other kind of questions or things you think we need to flesh out over the next couple of weeks, try to let me know and I can bring in any of the speakers or try to get material. Christian, I think you're right. There's a lot we don't have, but we are a small but mighty group. So I'm confident that we will do our best to put something together. And again, it has to go to human services and then council, but I think we can put together a framework, you know, better than anybody else, right? We're giving it our all, what we know about our community, what we think the needs are. And then we're going to stay together. We won't do it weekly, but we'll stay together to monitor how it's going so that we can try to tweak it along the way or get the staff the support they need or whatever it is, you know, because we want to make sure it's successful. So, you know, my vision is that our team will stay together through the year and kind of, you know, support this group, whoever they are, and make sure that they have what they need and hear from the community, maybe do some, you know, community forums to hear from the community about how it's going, do some kind of community engagement piece, making sure our nonprofits know who's who and how you contact them. I know there was a comment before about 911 and are people even going to call 911 for a non-police response? And so kind of working through that. I don't think we're at the point of starting a 211 because that's a whole other beast of something to work through. But, maybe we have some other kind of phone number. But maybe that's, maybe too many digits is too complicated. So that's a whole other piece we'll work through. But, I think that I think we're on to something. I think we can do it. Autumn Revelle and I can talk again, maybe to the city manager about the union piece. I'm not saying it's impossible, but we everything is bargaining here at the city. So I think part of my concern was not wanting this to get held up because we have to go bargain with the union, who we just last year had to ask to take a whole bunch of pay cuts and work for, take a bunch of free days off. So again, I'm a pessimist by nature, so I could be just woe is me more than I need to, but I'm much more concerned at this point with getting the program up and running so our community has another response model than fighting with our union. So, but we will have those kind of conversations. I can talk to HR just to see what that even entails. Maybe it's less than I think. And so next time we meet, I can try to have a little bit better picture about that. And then thank you so much, Allison, for joining us. If you think through who that, I think it was called what was the team called? The
Mobile access unit. Yeah, I'll get some more information on that too. And we also I'll have to look at, again, thresholds is really big and I'm just more familiar with our northern suburbs and stuff that we offer. But I do know that we also do partner with a couple hospitals as well to do outreach, much like Maureen was talking about at St. Francis. So there are a lot of different programs that we do have. So I'll try to get some more information or a better contact person for you, so that they would be able to kind of cover more of everything that we do, because I'm more familiar and just swamped with everything that's happening in Evanston and Skokie rather than all the other stuff that's kind of happening throughout our program.
Yeah. Well, thank you. I mean, even learning about what you're doing there in Skokie is important, because as we get this team going, we want to make sure they know about thresholds and they know about all the other options.
Yeah. And just to make sure we got that in the proposal, that we're going to have a community education piece, right? You mentioned a few elements of that, but I just want to make sure we formally recognize the need for that.
Yeah, and I know Chris Foss, he's on the line, and he talked about Chris, can you unmute for a minute? Can you remind us about the community? You were doing videos of community engagement, but was it 311 versus 911, correct?
Yeah, it's a number of PSAs in reference to calling 911, the expectations when calling 911, and when to call 911. I'd be hesitant to make them much longer than they're currently going to be. We're shooting for 3 to 4 minutes on each one, and there'll be 5 of them in total. I'm working with Anderson Castillo currently on that. But that should, kind of intersect a little bit, kind of in a Venn diagram sort of way with what you're trying to do.
Yeah. And I don't think, obviously we have to get this kind of up and running before we start any public education, but I just wanted to remind myself and the group that you were doing some PSA now. So, whatever we do will be kind of the second piece of a PSA, or however we decide to do it. But yes, Evangeline, I think ton of community engagement as it's getting launched, as it's going, kind of as a reminder. There's some things we can do in the city where we stick things in people's phone, water bills, because everyone gets a water bill. So just a lot of information. I'm kind of thinking maybe not to the scale, but a lot of the stuff they did to make sure people knew what 311 was when it was new. So, and even probably some palm cards and stuff that we can get to the nonprofits and get to our police, that they can then get to individuals they're encountering, and our EMTs and everything. So, right, because it'll take a while for people to understand what it is and how to get it and all that. But yes, so definitely the community engagement piece would be one that I would hope that we would be very much involved in. All right, so if there's anything else, just shoot me an email. I will get you guys this before the week. Actually, today's just Tuesday, so probably tomorrow or Thursday at the latest, with the Google link, so we can kind of remind ourselves. And yes, if you think of something, please email me. For those who are planning to participate, I think you've gotten the invitation. Tonight is the second night of the community shared safety conversation that we're doing. in the 9th ward. So it'll be more discussion in the first one. Evangeline will be there as our community ambassador. So if you want to participate, if not, I can send you the link because it'll be recorded. If you just want to hear what people in at least the 9th ward are thinking about a shared safety model of community life.
And then tonight is a mental health
Oh, yes.
town hall. Patty, do you know, can you tell us about that or?
Sorry, I think actually, Maureen, are you presenting
Oh.
there tonight? Yeah, so Maureen knows a little bit more about it, but
Yeah, so through the mental health task force, Evanston Mental Health Task Force, we're partnering with the library, and I can't thank Jill Swirsky and her colleagues enough for being willing to take us on. So we're going to do a 12-month series on different aspects of mental health. We're trying to come at it from the perspective of more of like I know this is going to sound strange, but more of like from a fun perspective. Like everything is really, really hard. So we don't want to do like hardcore education about like what is schizophrenia and what, right? It's just too much. But so more focused on encouraging resiliency, encouraging people to recognize the coping skills they're already drawing on, to think about getting support from each other, you know, in a different way. So tonight is a town hall, and then we'll be starting the programming in February. And Cindy Castro from Amita, who was on a previous call with us, she's helping to facilitate Spanish-speaking presenters. So our goal is that the series is, you know, each month is presented in both English and Spanish. So, but we're recruiting Spanish-speaking professionals to help. So tonight's really hopefully to just get a sense of what people are looking for. And so we'll see how it goes.
And that's at 7. I think the link is on the city website.
Yeah.
It should also be on the library.
On the website.
Yeah.
Yeah. So if you're really a meeting lover, you can do the 5:30 shared safety, and then you can jump onto the other one.
Good. I appreciate the recording of the shared safety. I have not able to haven't been able to make any of the meetings that I won't be able to today. So I appreciate having access to that.
Yeah, and there's only 2, so it's, you know, it's doable. But
Great.
there'll be more information once kind of a policy framework is developed. All right, well, my dog will let me know it's time to go. Thank you all so much, and so I'll see you next Thursday.
all right, thank you all.
Tuesday. I'm sorry, next Tuesday. Okay.
Take care.